I'd now like to invite Dr. Komanduri from University of California, I think that's what it is, to the stage. You're going to do an updates on lymphoma. Thank you.
Thank you. Yes, for those of you who don't know, I was at MD Anderson with Dr. Kadia for a while, and then University of Miami, and I recently moved back to UCSF, and really thrilled to be there. So still getting used to saying that. All right. This is, I'm not seeing my slides, sorry. No worries. Okay. So these are my disclosures. I think I will be talking about some recent data and approvals from Genentech. None of these are ongoing active relationships, so and shouldn't impact my conclusions that I make here. So I'm going to start, and I think I appreciate the challenges my colleagues have had in trying to summarize very complex and diverse approaches in CLL and myeloma. I would say we have a little bit the luxury of having more focused therapies in non-Hodgkin's lymphoma, and I've chosen not to take a broad, expansive approach, but rather than to talk about a couple of, I think, critical advances in the field, and hopefully that'll leave some time for discussion. So the first thing I'll talk about are a couple of, I think, important bispecific antibody advancements, and again, Dr. Yi just gave you a nice example of what bispecific antibodies are, talking about the data with teclistamab, for example, in myeloma. But just one, and I'm sure Dr. Kadia is going to talk about blinatumomab tomorrow, but bispecific antibodies just, I would say briefly, try to bring together recognition elements that bring T cells and a target that's present on a hematologic malignancy. And important to know, I think, with the context of this talk, that there are different constructs that can be used. Blinatumomab is actually a very simple construct that basically on one side has an engager for a T cell, and one side has an engager for leukemia. Mohsinetuzumab, which is looks kind of like a traditional antibody, but has a monovalent recognition for CD20 and then a monovalent recognition for CD3, but does have, again, the bottom of what the antibody is, which has ADCC or antibody-dependent cytotoxicity functions, as well as complement fixation abilities. Glofitimab, which I'll talk about and show you data with glofitimab in aggressive lymphomas, is a little bit different in that it has a bivalent or two recognition domains for CD20 and one recognition domain for CD3, and it's also been genetically engineered so that the ADCC and complement fixation elements are actually engineered out, so it doesn't fix complement. I think this is important because as we see this kind of dizzying field of progression of bispecific antibodies, we're going to have to try to figure out which constructs are needed and how are they associated both with toxicities and efficacies and persistence, because right now we have differences in structure, differences in toxicity, differences in duration of therapy, which is critical, I think, both from a perspective of quality of life and impact on the patient, but also with respect to the cost of these therapies. And I think these are all things that I would say, as you look at bispecific antibodies, don't think of them as one individual class, but think of them as an evolving approach that can be engineered in different ways, and that might affect both, I think, the properties of these therapies. So the first study that I'll talk about briefly was a pivotal study that led to the approval of Mohsinetuzumab monotherapy in patients with relapsed and refractory follicular lymphoma. These patients had received more than 2 prior lines of therapy, and I'm going to show you just some high-level views of the pivotal trial that was actually published in Lancet Oncology in the middle of 2022 and led to FDA approval for this indication in December of 2022. So these patients, I think, just to summarize what's highlighted in bold in the bottom left of the slide, most patients had advanced disease. They were very heavily pretreated, and they had characteristics that were associated with poor prognosis. So the median number of prior lines had to be 2 or more, but the median number was 3 and ranged from 2 to up to 10. And critically, these patients have pretty much mostly seen, they've all seen CD20-based therapies, and 79% of these patients were refractory to prior CD20 therapy. And then there were a large fraction of them, half of the patients were actually refractory to both CD20 therapy and alkylating therapy, and this was deemed as double refractory. So this is the critical and primary endpoint. The CR by independent review was 60%, and the overall response rate was 80%. There was strong concordance between investigator review and independent review in this approach. And again, this was in a very heavily and highly refractory group of patients was a very meaningful clinical endpoint. Again, if you look at the waterfall plot, you can see that the best response was a CR in a majority of the patients. And again, excellent overall response rate. This is the median progression-free survival, which was 17.3 months. And again, this led to the FDA approval in December. So conclusions, and I think this is really an important advance in follicular lymphoma, and also emblematic, I think, of the emerging and growing importance of bispecific T-cell engagers in the treatment landscape across hematologic malignancies, is that the overall primary efficacy endpoint was a CR rate of 60%. There were deep and durable responses in heavily pretreated and high-risk relapsed and refractory follicular lymphoma. Had a very favorable toxicity profile. Again, those of us who have been doing CAR T management know that a subset of patients will have severe toxicities like cytokine release syndrome or neurotoxicity. And again, there are seem to be some situational toxicities like the Parkinsonism that again, Dr. Yu just talked about. But here, I think we demonstrated that first-line T-cell engaging bispecific antibody. This is the first T-cell engaging bispecific antibody that demonstrated a very clinically meaningful outcome for patients with relapsed refractory follicular lymphoma in the phase 2 setting. And again, this is an off-the-shelf therapy. So unlike CAR T-cell therapies where we're taking a product, an apheresis product, it relies on engineering, manufacturing throughput, return to the center, and higher theoretically marginal cost, this is a therapy that's off the shelf. Now, of course, price and marginal cost of production and price are two different things. So I think that those theoretical advantages could be lost depending on, again, how products are priced and what the value is depending on what outcomes are achieved. So moving from Mohsinetuzumab to Glofitimab, these are really important results that have not yet led to an FDA approval, but I think that there's hope that they will. So Glofitimab was assessed, and this was again a recent publication in the New England Journal of Medicine, in patients with relapsed refractory large B-cell lymphoma and 2 or more prior therapies. And again, these are the pivotal phase 2 expansion results. In the prior trial that I told you about Mohsinetuzumab, duration of therapy ranged from 8 to 17 months. In this case, the investigators used a fixed duration treatment schedule, which was a maximum of 12 cycles. They did do some mitigation for cytokine release syndrome. Again, cytokine release syndrome is an inflammatory syndrome that we can see with CAR T cells. In the setting of CAR T cells, it's often severe. It can lead to hospitalization, a need for supportive care like in sepsis patients. In bispecific antibody therapy, this tends to be more limited, but can be severe in a subset of patients and therefore typically results in a need for hospitalization. For example, in this trial, patients were hospitalized for the first 24 hours after Glofitimab administration. But in this trial, cytokine release syndrome, they attempted to mitigate it by using Obinutuzumab pretreatment and then used a step-up dosing approach for cycle 1 and monitoring again after the first dose. So these are the baseline characteristics of the patients. You can see that the majority of these patients had diffuse large B-cell lymphoma, with the next largest grouping transformed follicular lymphoma. This is pretty similar to the kinds of patients that were enrolled in the first pivotal trials of CAR T-cell therapy. You can see that the majority of patients had 3 or more prior lines of therapy. And this is actually really important, I think, given the data that I'm going to show you later in CAR T-cell therapy. Fully a third of patients had prior CAR T-cell therapy. 86% were refractory to the last prior therapy. 56% were primary refractory, and again, 30% were refractory to CAR T-cell therapy. And again, a really critical problem right now is when patients who have CAR T-cell therapy respond, what happens after that if they fail? And I think that's going to be, I think, one of the most important problems that we have in diffuse large B-cell lymphoma. And I think this trial tried to assess those patients and say, is this a potential approach that can result in a meaningful response? So the answer is yes. So the overall response rate was 51%, and critically, the CR rate was 40%, which is not that far off from the CR rates of early CAR T-cell trials. You can see that the duration of response, that the median duration of complete response was not met at the time of this analysis. And again, you can see that the 12-month CR rate was 76%, so which again suggested promising long-term outcomes. So to conclude, and again, I'm not giving you all of the data from this trial, but Glofitimab is the first T-cell engaging bispecific monoclonal antibody to demonstrate really clinically meaningful outcomes for patients with relapsed refractory diffuse large B-cell lymphoma in a pivotal phase 2 setting. The primary efficacy endpoint was met, CR of 40%, overall response rate of just over 50%, and a very heavily pretreated, highly refractory group of patients with 2 or more prior lines of therapy. There were consistent CR rates in patients with prior CAR T exposure. The exposure, again, there was a higher CR rate in patients who were relapsed versus refractory patients, not surprisingly. And critically, the CRs were achieved early and durable even after fixed duration treatment, again, maximum duration of 12 months. And again, as you look at bispecific antibody therapies, think about how those trials are designed and how long that therapy has to be ongoing, very different than, again, the one-and-done approach that we see with CAR T-cell approaches that Dr. Yi discussed. So Glofitimab was well tolerated. There was a low rate of treatment discontinuations. There was cytokine release syndrome, and it can be severe, but it's mostly low grade. Most patients have fever alone or very transient hypotension, and almost always occurs during cycle 1. And I would say in separate data that I was working on in collaboration with investigators at Genentech and through the pivotal trials, there are actually pre-transplant risk factors that appear to identify quite well the patients who are likely to get into trouble. So it's probable that modeling, kind of like IPI modeling for lymphoma, can help us arrive at a subset of patients who probably can, maybe in the future won't need to be hospitalized at all, but that's something that I think is not what we see now. Most patients will need to be hospitalized for 24 hours, and that's how these trials were done, and that's likely, if there's a label indication, what will happen. So Glofitimab is a promising off-the-shelf treatment, again, with a novel mode of action, and again, the slightly different formulation than Mohsinetuzumab in terms of how it engages CD3 cells and CD20 cells. So it is being evaluated, I think, critically, not just in this setting, but with GEM-OX in patients with relapsed refractory diffuse large B-cell lymphoma. And again, there are multiple trials, including, again, that phase 3 trial and earlier phase trials, for example, looking at other co-stimulatory approaches that may result in different kinds of responses. So I think that it's very likely that we're going to see things that first emerge in the relapse refractory setting, and then they get disseminated to other phases, and I think this is going to significantly improve options, but I think it will lead to also complexity in the treatment landscape and meaningful questions that we're all going to have to answer together about sequencing and what therapies to use. And I'll talk a little bit about the financial implications of all of this later on. So where are we with respect to CAR T-cells? Obviously, one of the most exciting things, I'm a laboratory-based T-cell immunologist at my core, and so for me, I can tell you when I went to UCSF as a hem-onc fellow and a postdoctoral fellow, there was no cancer immunology lab that I could go into. And so I actually spent 3.5 years doing HIV immunology, which was very meaningful. It was at the peak of the pandemic, but to come back and see actually extraordinary individuals in my division really pushing the frontier of CAR T-cell therapies just shows how far have we come in roughly a quarter century. So this is a data that talks about the development of the registry. So the NCI actually encouraged the Center for International Blood and Marrow Transplant Research, which is based, again, out of the National Marrow Donor Program and Medical College of Wisconsin, to establish a registry so we could track outcomes and utilization of CAR T-cells. Now, unlike, for example, the allogeneic transplant registry, which is, again, a project that comes out of a government contract and a National Transplant Act, this is not required for all centers to again, submit all of their allogeneic transplant data, which we do. We submit volumes of transplant data on every allogeneic transplant patient in the US. So this is a voluntary registry, so it probably consists of about 50 to 60% of patients who have been treated so far, so keep that in mind. But again, so the NCI actually funded this registry pilot. And since then, again, this slide also highlights the very significant approvals that we've had in the CAR T-cell space. So first, Tisagen-Leclacel or Kymriah in the setting of young adults and children with ALL, and then Axi-cel or Yescarta was approved in 2017, in October of 2017 for large B-cell lymphoma. And then since then, we've had, again, effectively derivatives of Axi-cel, Tecartus being approved for mantle cell lymphoma and other diseases. And again, we've heard about the approvals in the CAR T-cell space of both ide-cel and cilta-cel. And again, beyond the original approvals of Axi-cel, we now have pivotal trials that I'm going to talk to you about in the second-line setting and approvals in the adult ALL setting and the follicular lymphoma setting. So this is, again, the registry at a glance. You can see that through the end of 2021, there are about 7,500 infusions. Of these, again, voluntarily submitted data, about 5 out of 6 of them are commercial products, and 1 out of 6 are non-commercial or experimental products. You can see that, again, very early on, it was mostly ALL, and then a huge jump in patients with non-Hodgkin's lymphoma. And now you can see on the right-hand side with the rise of multiple myeloma and other trials, you can see an increased heterogeneity. And obviously, we're going to see this eventually expand to solid tumors and other indications. So this was the first patient that I actually took care of. It was actually the first patient treated at the University of Miami on the Axi-cel ZUMA-1 pivotal trial. This was a woman who was 57 years old, had actually failed 6 prior lines of therapy, including 3 lines of experimental therapy, and had lymphoma encasing the aorta. Had the means to do everything. We actually had a decent performance status, but we thought that she probably had weeks to live at that point based on her clinical status and rapid disease progression. She got 1 infusion, of course, of Axi-cel in the pivotal trial, was incredibly unwell, had hypotension, a sepsis-like syndrome, and then had what looked almost like a pseudo-coma for 6 days, so she was very unwell. This was all new to us and new to even clinical trial investigators, so we gave dexamethasone. She improved, but it was a pretty terrifying process, but she came through that. And you can see that her staging scans in February and April were free of disease. Unfortunately, and I'm going to talk about the limits of CAR T-cell therapy, this patient eventually had a localized relapse, which was actually treated with radiation, but then had a progressive relapse, and she eventually died of complications of lymphoma, but 2.5 years after her initial therapy. So she clearly had a very profound and meaningful alteration of the course of her disease, but I think this is both an example of the remarkable success, but also where we are with respect to not being where we need to be with respect to CAR T-cell therapy, and I think that's going to be a theme of what I'm going to show you next, which is this is now the data that are actually in press in Blood. The manuscript has been uploaded if you want to look at it, but this has not been formally made the print edition yet. So this is Setva Nilapu's long-term follow-up of the ZUMA-1 study. In the initial paper that was published in the New England Journal of Medicine, follow-up was much shorter. This now reports median follow-up at just over 5 years, at 63 months. So what's the good news? Well, the good news is that this is a curative therapy. The 5-year overall survival is 43%. And again, I didn't show you the historical data, but if you look at, for example, the SCHOLAR-1 study that took 3 data sets and said, how might these patients who qualified for ZUMA-1 have done? Those patients were expected to have a very low overall response rate. Most of us would say that the likelihood of these patients being alive more than 6 months would be in the 5 to 10% range at best. So these patients had roughly 40% survival at 2 years, but now, again, at the 5-year mark, 5-year overall survival is 43%, and progression-free survival is 32%. Critically, patients who had no defining events, for example, a relapse, had 90% overall survival at 5 years. Okay, so does that mean that you're out of the woods? Well, not quite. There were 5 deaths beyond year 3. One did have progressive disease, which we kind of think, maybe shouldn't really happen, but it can after 2 years, and one had a secondary malignancy. So these are not trivial events. And there were 3 other deaths, and I think we can't be too cavalier about not attributing those in some ways to prior therapies. Secondary analyses, and I'll show you this in the next slide, report an association between early CAR T cell expansion, that is peak numbers in AUC, and maintenance of long-term responses. So this is again, the median overall survival curve. And you can see on the right the exploratory analysis of the CAR T cell peak, that is, how high did the numbers get? And they looked at both an AUC here, as well as kind of, again, a median peak cells per microliter. Actually, this is the CAR T cells in cells per microliter peak. And you can see that patients who had a higher peak initially, that is higher expansion, had a better ongoing response. In fact, they were less likely to either be non-responders or to have a late relapse. So moving from the 3rd-line setting where we saw our first approvals to the 2nd-line setting, is cell therapy the standard of care for 2nd-line diffuse large B-cell lymphoma? And I would say yes with an asterisk, and I'll explain that. So there are 3 pivotal trials of CAR T-cell directed at CD19 in the 2nd line. So this is not all patients who relapsed, but patients who were either refractory to first line of therapy or relapsed within 12 months of first-line therapy. So this did not include, for example, patients who relapsed at 18 months after therapy. So these are high-risk relapses. So these trials, in principle, looked at how the normal approach, which would be giving salvage therapy with, for example, rice or other therapies, and then seeing if patients had a partial response. If they had a partial response, they would go to high-dose chemotherapy and autologous stem cell transplant, which has high curative potential and really low morbidity and mortality. In most of our centers, we would quote somebody maybe a 1% to 2% mortality rate, but in most of our centers in practice, it's really more like 1 in 200. So we have very low mortality despite what people think about as the morbidity of autologous transplant. So versus CAR T cells now in the 2nd line. But how are these trials done? And I think this is important. So one way to do this would be to randomize patients and then give them all salvage therapy. And if they responded to salvage therapy, which would be a normal process for going on to autologous transplant, give them an auto transplant versus CAR T cell therapy. But that's not how the trials were done. I think that's an important caveat. At the time of relapse, patients immediately had to be randomized to either CAR T cells or salvage. And the patients who then responded to salvage went on to an auto transplant. So this is not really a trial of CAR T versus auto transplant. Because if you look at the study, for example, the ZUMA-7 study that was published in the New England Journal of Medicine, less than 40% of patients actually went on to the auto transplant. And actually, what does that tell us? It tells us that our current approaches to doing salvage therapy are pretty bad, right? So rice results in a response in less than 40%. So most patients aren't going to get an auto transplant. It doesn't directly answer the question that if you can get an auto transplant, you'll do better. So what do we know about that? So this is work from Marcello Pasquini and others looking back at the Center for International Blood and Marrow Transplant Registry data at patients who had auto transplant versus CAR T cell therapy at progression-free survival and overall survival following salvage therapy. And actually you can see here that in these registry analyses, again using the modest amount of CAR T data that we have to date and a very large amount of auto transplant data historically, that if you look at patients who have a PR following salvage, and you looked at patients at that point who had a CAR T cell therapy versus auto transplant, CAR T cell therapy isn't obviously better, right? So why does this matter? Well, in many cases, we're not called the moment that somebody relapses. They're often being given a cycle of rice in the community, and many times they've responded, and then we have to decide what to do. That's not how the patients presented in this study. Patients had to be recognized by their referring doc, had to immediately be, they had to call up one of the treating CAR T cell centers, and then before they got any salvage, had to be randomized to either salvage or CAR T cell therapy. So there are a lot of selection layers there that may have affected the approaches. That said, is it the 2nd-line standard? I would say yes. 2 out of the 3 of those randomized control trials, ZUMA-7 and Transform, favored CAR T cell therapy in the 2nd-line setting. While we don't have real data yet, Kite issued a press release just in the last week or so saying that not only was there progression-free survival as they saw in the ZUMA-7 NEJ study, but that there's an overall survival benefit. I think we don't know enough about that to, I think, be able to evaluate that. But these RCTs demonstrated that salvage therapies are suboptimally effective. For example, less than 40% achieved a PR and had an auto transplant. So retrospective analyses suggested that those individuals who have a PR can do quite well. Kind of a practical question is for somebody who's in the community and may have received salvage and is responding, what do we do? Many of us, and I've been in again, groups of expert panels, many people would say, well, in that case, I would probably see if they're responding and then take them to an auto transplant, despite these data suggesting that again, the CAR T-cell therapy is the appropriate thing in the second setting. All of these current data are prone to selection bias. Additional data, including from registries that actually look at things in a less biased way, are needed. RCTs would be helpful, right? We would love to compare these products and compare these things in better ways. They're not going to happen. There aren't any CAR T RCTs comparing one product to another, and that's a limitation that I think is a problem. So what about fourth line? Well, we need better therapies following CAR T failure. You saw the encouraging data about Glofitimab in patients who had failed CAR T-cell therapy. And there are other data, for example, on CD22 recognizing CAR T-cell therapies emerging from the Stanford group, Crystal Makel and Dave Miklos and Matt Frank and others. But long-term results of all three commercial products suggest only 30 to 40% cure rates. You saw the 32% progression-free survival at 5 years in ZUMA-1. So CAR T trials, including of CD19-22, in patients who have failed a prior CAR T-cell typically have demonstrated less than a 30% overall response rate. So we have response rates, but they're not great. So I would say second-line CAR T therapies, that is following the failure of a first CAR, are really needed. And then to talk about another whole spectrum of the disease that I'm not going to summarize here, but again, Sutphen Ilpu, my colleague and Tappan's colleague at MD Anderson has demonstrated in the ZUMA-12 study that first-line CAR T therapy is promising, but I think additional data and randomized control trials are needed. So can we predict failures? Well, so if you lose response to a CD19 therapy, you can imagine that could happen because the T cells aren't present. We think of these as a living drug, but the reality is in most of these trials, the T cells are actually gone by 6 months. So if, and perhaps that's a T cell intrinsic thing. Maybe these T cells are kind of burnt out in the patient, or maybe they're cleared by an immune system that's getting rid of those cells. Or in other cases, perhaps, and we know that this to be true, that relapse is due to antigen escape, that now the lymphoma evolves such that it doesn't display CD19 on its surface and is no longer a target. So CD19 deleted or mutated or no longer expressed. So these are data from really a trial that was negative from my former colleague in Miami, Jay Spiegel, who recruited from Stanford, looking at a CD19 and 20 bispecific CAR T-cell therapy. And I would say largely the therapy did not have great responses, less than 30% overall response. But interestingly, they looked using a quantitative approach. So normally you'd have immunohistochemistry and a pathologist says positive or negative for CD19. Well, what if you look quantitatively and say, okay, among these individuals, who has more or less CD19 on their surface? And they did that here. With both CD19 and CD22. And they basically looked here at quantitative flow for CD19, and they demonstrated that individuals who had lower amounts of CD19 prior to treatment were more likely to have failed this experimental CAR T therapy. So it's possible that these are the kinds of things that will tell us, okay, you are more or less likely to respond, and maybe we need a more effective or a combination approach or a different approach altogether. So this is, again, Jay and I wrote an editorial in Blood last year on another study looking at checkpoint inhibition in combination with CAR T cells after failure. But this is from a model that he and David Miklos had derived. So CAR T product fitness matters. What happens in the patient in terms of prior chemotherapy may affect the T cells. Tumor biology matters. What is the antigen density in the beginning? What is the microenvironment? There are cells like suppressive macrophages that we know can inhibit cell-mediated immunity. And then, like we're used to thinking about drugs, what are the pharmacokinetics and pharmacodynamics? Well, we were all sold this promise of CAR T cells being a living drug. And there are indeed CLL patients who are out from the early studies, some of the first patients treated by Carl June and David Porter at Penn, who have demonstrable circulating constructs, now more than 10 years out. But in the vast majority of patients, these T cells go away. So how does the pharmacokinetics and pharmacodynamics matter? You saw, again, a hint that may really matter in that Sutphen Ilpu long-term follow-up. So some of the things, and this is a beautiful slide from Julia Carnevale, who had a wonderful Nature paper trying to modify with CRISPR technologies CAR T cells so that they're better persistent and perform better in hostile environments. But there are a number of things that there are people in my division and others who are working on. How do we improve traffic and infiltration? How do we deal with this issue of proliferation and persistence? How do we deal with tumor heterogeneity? I mean, if there's a subset of a tumor that doesn't express a target, well, how can you expect it to be completely responsive? Do you need to use now 2 CARs or other approaches that gate in a logical way signals? And then again, the immunosuppressive tumor environment. And I won't go into. I could do a talk on the synthetic approaches that are being used to approach all of these. So what? Just forward thinking, what developments will make a difference? Allogeneic therapies are promising, additional targets are promising, and K-cell therapies are exploding but have very limited data to date. And really, we only have one approved pediatric product, and despite the fact that there are both lymphomas and leukemias in children, and that's really a disparity. And we need better treatment predictors. So the last thing, I think it's important, and it goes hinted on by Dr. O'Donnell this morning, the geographic distribution of patients who have received CAR T cells is here, right? And one thing I'll show you is look at the top right. 13% of the US population is African American. And yet, if you look at who's been treated so far, 5% of patients who have received a CAR T cell therapy are African American. I didn't talk about it, but if you looked at even the first 100 patients who were treated with pediatric ALL CAR T cell therapy, patients who were Black were much more likely to have more rounds of therapy, had lower response rates, lower survival at 6 months. So not surprisingly, perhaps, but I think it should wake us up. Historical, socioeconomic, geographic, educational, and insurance barriers are magnified when it comes to curative and very expensive therapies. So all approved CAR T-cell therapies in aggregate are underutilized. Based on the registry data, and this is to me shocking and depressing, that probably less than 30% of patients who meet the label criteria for third-line relapsed refractory CAR T-cell therapy 5 years after approval are receiving those therapies. That is really bad, and that's something that all of us should really be thinking about and trying to fix. High-cost tertiary or quaternary therapies tend to maximize historical barriers, again, whether they be racial, socioeconomic, logistical. And again, early data suggests that they're less likely to receive therapy, 5% versus 13%, and have lower ORR and CR rates. Is that biology? No, it's the fact that they're coming to therapy later and being less likely to referred with the appropriate indications. So, and again, unique issues exist for our pediatric populations for whom fewer treatment exist, and many companies have therapies that could be done and trials that could be done in pediatric populations, but they're just not doing them. So how do we improve access? And this is from a review I wrote in the JCO a couple of years ago. If we take this thing, if we take patients who are diagnosed, some are referred, CAR T cells are collected. Manufacturing, Dr. Yee didn't talk about it, but manufacturing has been a major problem, especially in the myeloma setting. Most of us have dozens of patients who are waiting, and we get 1 or 2 or 3 or 4 slots a month, and that's a problem. So, and then some patients have lethal toxicities. Fortunately, we're getting way better at that, but many patients will relapse. The majority of patients, even with these really transformative lymphoma therapies, are relapsing, and that's a problem. We have to find ways to improve those outcomes. So how do we do that? We have to really streamline and scale manufacturing approaches, better educate patients and referring physicians, develop less costly therapies, and really look at value, which is different than cost, right? So we can do things, and there are ways of assessing, again, quality-adjusted life year benefit with therapies, and I think we have to all, collectively, and the developer and the clinician side really be thoughtful about that. So I'm going to stop there and just note some individuals who I stole slides from: Jay Spiegel, Marcelo Pasquini, Miguel Perales, and Gino Laporte, and obviously thank the many patients who put their confidence in all of us together to make these advances happen. Thanks. Yeah. Okay, yeah, Bruce.
Thank you very much. I would now like to invite Dr. O'Donnell up to the podium to moderate our Day 1 panel discussion session, as well as Dr. Yee and Dr. Graff.
Can you guys hear me? Am I turned on? Okay, great. Thank you. All right, what a morning. No, I'm not. All right. I think I can do this blind. Now am I turned on? There we go. All right. What a morning. Those were some really exceptional